Hey, this is Brandon Steele with ChiroUp. On to the next topic that we're going to talk about today, that being thoracic outlet syndrome. Thoracic outlet syndrome is actually one of my favorite diagnoses within the shoulder. Yet the symptoms may be wide-ranging, meaning I used to think thoracic outlet syndrome was a whole arm problem. We had a neural problem, we had a vascular problem. And while that is true, I think that and definitely earlier in my years in practice, missed a lot of these, meaning I thought that I had ulnar nerve radiculopathy type patients. In actuality, there was a peripheral compression at the thoracic outlet. So I think this is one of those lectures that we all know the signs and symptoms. We can all think of 10 patients that have these kind of symptoms. And sometimes we forget about the obvious choice. And in this case, what we'll talk about is thoracic outlet syndrome. Preceding this lecture, we've talked about impingement syndrome. We talked about scapular dyskinesis and rotator cuff syndrome. I think that this is a continuum of issues going along with the shoulder. Maybe not as quite related, meaning a lot of those things with scapular dyskinesis, impingement, and rotator cuff syndrome, even going through SLAP lesions, is really a continuum that ends up usually in more of a adhesive capsulitis. Thoracic outlet syndrome, I think, is more of a compensatory type diagnosis, or another diagnosis in the shoulder that doesn't necessarily fall within that continuum. You can have it in isolation, or it can be part of that continuum. It really depends on the person and the activities. And with that being said, it truly is dependent on those person and those activities, just like every other diagnosis. The good thing about thoracic outlet syndrome is that it is a little bit unique. It's one of those things that these patients have seen a lot of different providers, probably me in my younger years, who misdiagnosed it. And I think that whenever we can identify it with confidence, then we can have a treatment strategy that helps a lot of these patients. So most of our TOS patients are going to have more of an upper extremity paresthesia that's caused from occlusion, compression, injury, irritation to the neurovascular structures that are going across that thoracic outlet. And I say neurovascular because it can be any number of compressive structures. It can be the nerves, or it can be that subclavian artery or vein. And we'll kind of discuss the difference between all three of those. Fortunately, the one that we can affect is the most common and also is reversible. When we have arterial issues, one that usually falls outside of our scope of practice and is significantly more serious to the patient. So when it comes to arterial TOS, here's when we have, occlusion, something blocking the actual subclavian artery. It can be from stenosis of the artery, from an aneurysm, from embolus or compression, maybe from a cervical rib or past injury or trauma to the clavicle. This is the most serious cause of TOS. This is less than 1% of those people who have TOS. When you have TOS from an arterial occlusion or compression, or just blood's not getting through to the arm, you can imagine that a lot of times with this, you're going to have coldness, you're going to have fatigability, you're going to have diffuse achy pain throughout the entire arm as you're cutting off blood supply. This is a very serious condition, and the way I usually teach this and tell patients is that this is a diagnosis where I drive you to the emergency room. This is a very serious problem. It needs to be addressed ASAP. Its sister is a more of a venous problem, and this is when the subclavian vein is now being obstructed. So now you have blood getting into the arm, but it's not coming back out of the arm. So now we have too much blood in the arm. So this would be more of your edema. This would be more of your cyanosis, venous dilation. Blood's not able to come back. Now this is less than 5% of all TOS type injuries. So it is still less. It's not as serious as arterial. And the way I think of this is where my staff drives you to the emergency room. Now I have had patients. In fact, I have a patient right now with venous TOS. She has dilation of the veins. You can see right in her hand, but it's been determined it's not not serious, it's not within the lumen, and it's more compression from a cervical rib or clavicle. We'll talk about that in the next couple slides. So this is serious, but it's not life-threatening. A variant, a form of this TOS is also called Paget-Schroeder syndrome, and sometimes we'll call this more of an effort thrombosis, meaning we see people throwing clots into the arm, and the reason for that is because of repetitive strain. We'll see this in baseball pitchers, that constant external rotation, really stretching back there in the late cocking phase of arm motion, is they're putting stretch and constantly irritating that tissue, and then we can have issues in the blood vessels because of that, and we'll have TOS in professional pitchers. The other 95%, fortunately, is less serious and also stuff that we can have an effect on. So this is when we have actual mechanical compression to the neurovascular bundle. So when you have these kind of patients, that's something that we can have an impact on. This is the most common, the 95% of cases that we're going to see, and we're getting compression of the lower or the medial cord of the brachial plexus. And if you can draw out the brachial plexus still after you've been in practice, I'm impressed. But really what you want to know is the bottom part of that brachial plexus, because that location is why it's getting compressed. And we'll go over the exact nerves and what we can do about it as we go through these slides. So where does this compression happen? Well, really, when it comes to TOS, it can happen in three spots. This is a peripheral compression, a peripheral irritation. So we can have it at the scalenes, right between the anterior and the middle scalene muscles. We can have some irritation there. We can also have it down near the pectoral region, the pec minor tendon way down here. And we can even have it at the first rib and clavicle area, right in this area. So that'd be more the costoclavicular type compression. So these are my three types, and I think that we can also have, from literature, we can see cervical rib issues. Now, when I say this, less than 1% of people have cervical ribs. When you do have a cervical rib, the chances are 80% of you have it on both sides. And TOS is usually only on one side, not on both sides. So there's some discrepancies in the numbers, and less than 10% of people with cervical ribs have TOS. So is it possible? Yes. So it is possible cervical rib could be the cause of pain, but with less than 10% of people having TOS who have a cervical rib, it's possible. But is it probable? Probably not. Is a cervical rib a space-occupying lesion? Yes, it just is. There's another piece of hard tissue in the area. Can it be related to TOS? Yes. But I wouldn't look at an x-ray and say, yes, you have a cervical rib, so you must have TOS. That would be the kind of deductive reasoning that would get you in trouble. More commonly, we're going to see injuries. When you have a prior clavicle fracture, and the way clavicle fractures are the most common are in the middle third, so between here and here. If you have a fracture in the middle third, that's a very unlikely injury, more of a traumatic blow injury, usually life-threatening. Most of them are at the middle third or the outer third being a fall at the tip of the shoulder. But these kind of fractures can create a separation at the AC joint, or this one would actually cause a non-union healing event where now you have bone where there should be soft tissue. So another space-occupying lesion. 23% of soft tissue injuries can result in a TOS type symptom. So we really want to take that into consideration. While a lot of clavicle injuries, and what I've seen are my AC sprains, even the ones that are displaced, are not getting repaired. It's a cosmetic surgery. It's not a life-threatening surgery. So unfortunately, it's not covered by insurance. The other kind of space-occupying lesion is just having bad posture. Now, when you put yourself in a shoulder rolled forward posture, like our computer users, like our assembly line workers, like our supermarket checkers, and our students, our swimmers, our volleyball players, All these things that really cause increased stress compression of the muscles in the front part of our torso can aggravate these kind of symptoms. So all these things can add up to turn into TOS. And the reason I say that is S. It's a syndrome, thoracic outlet syndrome. These syndromes are a collection of symptoms. It's not one specific problem. It's everything adding up to cause this syndrome. We see this more common in women. We also see this more common later on in life, and just because kids are a little more immune to these kind of issues. So we can have a lot of, your habits, your hobbies, your posture, all these things can add up to create the symptoms that we're going to call a TOS. Now, if we have neck and arm and hand pain, a lot of this time it's going to be following an actual nerve root. So pain, paresthesia, motor weakness in the CAT1, which is the ulnar nerve distribution, that can be a sign of an actual TOS. TOS, and the reason it's affecting the ulnar nerve is the very bottom part of the brachial plexus. It's going to take the most compression because just a proximity to the clavicle and to the thorax. So we really want to make sure that we're very good at taking a good history, but also a neurologic evaluation to come up with the right diagnosis and rule out other possible diagnoses. So when we have this, we can all see where the ulnar nerve goes, and we'll, of course, assess this. However, also think about where that ulnar nerve goes. I used to call it my funny bone. So it goes right between these two condyles, the medial condyle at the elbow. And if you knock on that like a Tinel sign, you can aggravate the ulnar nerve. But what else happens with nerves? Nerves don't like being stretched. They don't like being stretched for long periods of time. What happens when you're sleeping like this? What happens if you keep your elbows bent, like holding a phone? I see this a lot, in fact, with my own wife as a runner. So they keep their elbows up and their elbows are flexed like this as they're running. And now your elbows are continually flexed, putting stretch across the nerve and can cause neuropathic pain. When we have long-term neuropathic pain, that's when we can go into actual atrophy, actual motor deficits, diminished grip strength. But this takes a long time to happen. Now, if you have actual reflex changes, sometimes it's a little more of a central pathology. However, most of the time this is going to be due to these peripheral events. Long-term problems can cause neuropathy. I mean, if you leave compression on a nerve, the nerve innervates muscles. In this case, the flexor carpi ulnaris, and I think it's the medial half of the digitorum profundus, start to atrophy. If the nerve's not getting signals to the muscle will start to get smaller. I've never seen this in practice, fortunately, but I've had several TOS patients. I think if we left it for a long period of time, it might come to this. When it comes to the evaluation of TOS, I think this is a lot more straightforward than people make it out to be. I'm going to keep Roos test on here. However, that test is not favored in the literature anymore. I still think it's beneficial because it will help a patient understand their symptoms, and I'll talk about that when we get to that evaluation. However, what we're going to really find are hypertonicity. We're really looking for hypertonicity in the scalenes, the pec muscles, and that would be upon digital palpation. Of course, we're going to look at the cervical and thoracic spine, motion palpation, see how the things are moving. And the one thing that often gets lost in our evaluations and treatments as we go along in practice and stay in our own little box and not have people looking over us is really looking at the first rib and the clavicle. What we did in scapular dyskinesis, that lecture, is talk about the SC joint, talk about the AC joint, making sure those things are moving, because if they're not, that's another sign and symptom of creating compression and irritation at the same level. So of course, put on our chiropractor hat and make sure the joints are moving well. Looking at this, we can look at the cervical spine and look for as far as imaging, as far as an evaluation, to look for cervical ribs. However, this is unusual. So we're not going to see a lot of issues with cervical ribs. It can happen. It's just not a normal problem, and it can cause significant issues in some cases. More than not, the thoracic outlet syndrome is actually due to the architecture of the cervical spine, the same thing that we're going to see in the cases with carpal tunnel syndrome, that being a double crush injury. So you can have cervical degenerative changes causing some irritation of the nerves, and now it's just creating a little more irritation at the scalenes, the the costoclavicular area, where you're starting to get this syndrome type effect like a carpal tunnel syndrome. And now you need to really address both areas. There are things that are a little more serious, kind of like a Pancoast tumor, that can also be a space-occupying lesion that would be identified on imaging. Diagnostic ultrasound, from what the emerging research is showing, is a very viable way of looking for these type of issues, because with diagnostic imaging, we can really put the patient in a variety of different positions that can cause compression to the brachial plexus with the arm in abduction. So it's kind of neat because you can look at how everything reacts, more specifically how the vasculature reacts. Are we seeing changes in blood flow with arm position? Can maybe help visualize any kind of arterial or venous TOS. Cervical MRI can also look at inflammation. It can also look for other issues. We can do diagnostic studies along with EMG and NCV studies to really look at which nerves are involved. Not my area of expertise, but it's always one of those things that if you're not quite sure, call in some more people, get some more eyes on it, do some more tests if you have somebody who's not responding to your care. What I do in my office are obvious orthopedic and functional tests. So once I have a clear idea of what I think is going on with somebody, I'm going to do the most specific and sensitive tests for those type of diagnoses. Morley test, or the brachial plexus compression test, is a good place to start. I love these kinds of tests, meaning if you push on it and it exacerbates symptoms, chances are you're in the right area. So whenever you do long-standing compression or palpation to the supraclavicular fossa, it's going to reveal some tenderness in the area. But if you really throw a little bit more force in there, slow, steady compression, it will elicit those distal symptoms going down the fourth, fifth digits, and that's present about 68% of people in TOS. So you push on the nerve and it aggravates the symptoms, it peripheralizes the symptoms. So one of my favorite tests to at least start with, because if it's positive, then I just need to figure out what area is causing most of the compression. The reason I said Roos test is not a common test that's being performed now is because of the time component, meaning there's a lot of things can be causing this kind of TOS. However, I still do this test with some patients because it reproduces symptoms and what they're doing in their actual life. Now, Roos test, what we can see here, is the patient's going to be putting their arms up, which is going to be squeezing her hand, and it creates a little bit of load, creates a little bit of demand at the muscles and the vasculature on the arms. And while I don't care so much about that, what I do care about is what does a patient do all the time. And with my female patients, they're doing their hair, and they get symptoms and signs of their problem when they're having to keep their hand up. And I'm not even going to pretend like I even understand what they do with a blow dryer and a hair straightener and those kind of things, but that's when you see the patients have their symptoms. So it does reproduce that mechanical sensitivity and help a patient understand what's going on and what they can do to fix it. Now, Wright's test, I do like. Now, with each one of these tests, we are going to be monitoring the radial pulse, looking for any kind of diminution in pulse, and also, of course, concurrent reproduction of symptoms. So I'll be going through there and seeing what I can find. And now what we're doing is we're stretching that neurovascular bundle across that pec and stretching backward. I'm going to hold there, I'm going to feel for a pulse, and I'm also going to look for reproduction of those distal symptoms. The reproduction of the chief complaints that patient came in with, most notably pain, numbness, tingling, sitting down in the fourth and fifth digit. Adson's test, click here. So now we're going to be seated. We can do Adson's test and also modified Adson's test. So we have a seated patient. We're going to rotate their head towards the side of being tested and now extend back. So as you can imagine here, we're compressing between the anterior middle scalenes, that neurovascular bundle, once again holding the radial pulse. And I can also do modified Adson's test where I can rotate to the other side. So Adson's test is rotating towards and compressing that area versus modified Adson's going away and really pulling now at the intractioning the nerves that exit out of that anterior middle scalene. Both of them will be appropriate. However, Adson I think has a little bit higher sensitivity and specificity. Costoclavicular maneuver is very similar to Wright's test, however, and still monitoring the radial pulse. But now what you're going to do to actually decrease the space in that costoclavicular space is she's going to bring her shoulder blades together. And by doing that, that exaggerated military posture, you're going to compress that costoclavicular space and now looking for changes in blood flow, which would be at the radial pulse, or reproduction of symptoms in the hand or elbow. Now, one lesser known test that I find very valuable, one to help diagnose this condition, but I think more importantly to lead the person into treatment, would be looking at the ulnar nerve, the most common nerve that's affected. And when we can look at nerve tension tests, we can really see where that mechanical sensitivity of these nerves reside, and can we affect it? Can we increase glide, increase stretch the nerve to relieve symptoms? We see this a lot with sciatic nerve flossing, with median nerve flossing for carpal tunnel syndrome. And really we can do these positive neurodynamic tests to see if we can affect those neurogenic symptoms. And through nerve flossing, which we'll show here in a minute, we can actually cause a little bit of peripheral sensitization to take away their symptoms. So the ulnar nerve tension test, I'm going to put some stretch across the elbow right here. I'm going to traction down at the shoulder. I'm going to flex her wrist, really putting stretch right across that ulnar nerve. I'm going to really pull at it and bring her elbow into more flexion, and now pick the arm up. People with ulnar nerve issues can't do that, meaning just doing this motion, they're going to start to feel numbness and tingling, and they're not going to be able to go any further. That's telling you there's excess compression somewhere along that chain. With neurodynamic tests, the first joint that you flex or the first joint that you stretch as far as that nerve goes, whether it's a flexion or extension of a joint, is going to put the most tension on that nerve. If you haven't done any kind of nerve tension neurodynamic maneuvers, we of course have all of those, teaching you how to do that within ChiroUp. A great book is Michael Shacklock's book. I highly recommend attending one of his classes. He does a phenomenal job, great educator. His book, Clinical Neurodynamics, taught me most of what I know. Really an excellent book. I can't recommend it enough for the ulnar nerve and TOS, but also more importantly, because we see it a lot more frequently, but getting into the median nerve, and then also femoral nerve and a sciatic nerve and leg have been lifesavers for me and my patients to help take away nerve symptoms. Nerve symptoms are sometimes pretty difficult to go away. They're not responding to chemical problems at a certain point. They're more of a mechanical issue. And nerves are designed to move and to flex and to stretch and compress just like any other tissue in our body. And when you have an injury around a nerve and you go through a healing process, sometimes that nerve can get adhered to the structures around it, like little spot welds is the way I explain it to my patient. And now when you try to get back into normal range of motion after your injury, after your sport, after what have you, you're not getting the same sliding mechanics of that nerve, and now you have abnormal tension or compression of the nerve that needs to be restored. And neurodynamics, I believe, does a great job of that. Now with TOS, which is numbness, pain, tingling, going down in the arm, there's of course a lot of other things that be causing this. So I am skipping over it, but keep that in mind. We need to make sure that we have no other red flags. We need to really address the other possibilities, meaning a lot of times they do truly just have an elbow problem, a golfer's elbow, medial epicondylitis or epicondylosis, a tennis elbow. We can look at other types of issues. Maybe it is truly just a cervical radiculopathy, but that's when we need to put our hat on and figure out, where we think the primary site of dysfunction is. So what do we do for these problems? Well, what is the management for a TOS? And in the previous the talks, we can go through and we can look at, soft tissue manipulation for the pec minor, stretching that out. We've already seen those in the past lectures. You can do soft tissue manipulation of the scalenes, and I think that there's a lot of value in that. I think that if I could teach you, or at least bring your attention, one thing that's been beneficial for me and also has a lot of efficacy in the literature is an ulnar nerve floss. An ulnar nerve floss is a practitioner-led movement to help get that ulnar nerve to start to move again, to break up those adhesions and allow it to floss, allow it to move better to help with those symptoms. So nerves are designed to move. So how can we get it to move better? I think the flossing is a great way to do that. Keep in mind, we're always going to start to flex the site that we think has the most compression and irritation. TOS, I think a good portion of it can come from the elbow, or also up in this area with the scalene, costoclavicular area, and pec region. So what you see there is I pull down on that first, and when you pull down, you're creating some tension there. And now I'm going to start to pull that nerve from below. I'm going to flex her wrist and fingers. I'm going to bend her elbow there, and now I'm going to bring it up, and I'm really going to put a lot of stretch on that ulnar nerve. And I can keep on doing that, tug at it, and as soon as I get symptoms, reproduction symptoms, then I come back down. Some people are only going to go to here and they start to feel it, and then I come back down, and then I keep on going up. Within 3 to 4 sets of 10 to 15, you're going to start to get more stretch, more range of motion, and you're going to go higher and higher with that. Now, you don't want to push through. Whenever you have an increase of stretch of a nerve, that's really about as far as you want to go, and then come back down. So any kind of reproduction of pain, achiness, numbness, tingling, that's your stopping point. If you have sharp pains that are shooting down your fingers, you're going just a little bit too far. Be gentle with it. And the reason I say that is not only because you're doing this now, but what you're going to see in the next 3 to 4 slides is we're going to have our patient doing this at home. Me doing this 3 times a week for 3 minutes isn't going to be enough. We need the patient to take what they've learned from my 10 minutes with them, and they can run with that at home to help with their symptoms in the long term. So as far as the actual, rehabilitation side of this, the exercise piece of this, I think this is where the true gold comes in the treatment of TOS, because we can do manipulation, we can loosen up joints, we can take compression off nerves, we can do some ulnar nerve flossing. However, it's what the patient does in the other 99% of their day that's going to make all the difference. And definitely with a diagnosis like this, there's a lot of things they can do for themselves. They're going to help them in the long run. Now, this is, which I didn't realize until maybe 2 years ago, and I had this fascination with exercises. With ChiroUp, we track every metric to see, what people are looking at, what they're not looking at. And as it turns out, this is the most common exercise prescribed across the entire world. So this exercise, the most common, and I think that there's a good reason for that. One, we have it in a good number of our protocols. However, people customize all their protocols to put in whatever exercise they want to do. This is part of directional therapy. There's a lot of people who take McKenzie class. I think it's a very great class to take, great training to take. But even if you don't, if you understand the mechanics of the cervical spine, if I have my head here and I do this, I really take that intervertebral frame and I make it smaller. If I can just take my chin, retract it, and essentially grow taller as I do that, and you can do this on a model, you can do it at home, it takes that intervertebral frame and makes it bigger. So you can imagine that if you have a cervical disc lesion, you have radiculopathy, you have weakness in the longus colli and capitis, now you're strengthening those. You have tension in the back part of your neck and the suboccipitals and the upper trapezius, scalenes. This exercise really can make a dramatic impact on a lot of upper extremity issues. So the cervical retraction exercise, I have my patients do frequently, and in fact, frequently being every single hour. So one set of 10 repetitions every single hour that you're awake. Some of your female patients aren't going to like doing this because it does create a double chin, but if it does create a double chin, they're doing it right. It's when people start to do this to the side and they go down or they come up like this, that's what's going to create an issue. You can add overpressure like you see there, going back and retract. And when you can really go back, retract, and you go as far as possible, it even will cut off a little bit of airway there, going into a full range of motion. Don't do that for a long period of time. However, you can get a lot of good range of motion, and it can help with things like TOS because, as we said, TOS a lot of times is a double crush injury. So cervical retractions will help in a long way, along with just having better posture. Now, the one thing that I think, until people start to really dive into neurodynamics, they're not going to really use off nerve flossing a lot in their practice. I think this is a mistake, to be 100% honest with you. This is one of these tools that we can use that when people have radicular symptoms, flossing of these nerves, tensioning of nerves can really make a dramatic impact on a lot of these people's signs and symptoms. So ulnar nerve floss we're going to cover right here. However, let's just for fun, let's do the median and the radial nerve. We're going to do the median nerve first because this is the most common one. However, what you're going to see here is take your fingers and spread them out as far as you can like this. And I want you to the side, go all the way out. I want you to extend your wrist. So you're bringing it back. And then as you do that, you're going to bring it behind your body as far as you can. Some of you are going to start to feel a pulling, a numbness, a tingling in your fingers. If you don't, take your opposite ear to your opposite shoulder and you'll start to feel a tugging of that nerve. That's putting tension on the median nerve. And you can look at median nerve flossing in ChiroUp at any time. Ulnar nerve flossing is the exact same. So let's go and take a look at this. So ulnar nerve flossing is a very similar way, but now she's going to put her fingers and her index finger and her thumb together, and she's going to slowly come up and try to look through the opposite side. When you do that, if there is tension, abnormal tension and adhesions along there, you're going to feel that numbness or tingling going into your fourth and fifth digit, which is what that ulnar nerve supplies. What I would have my patients do is to continue to do this maneuver until they can reach that full range. Maybe it's just right here. That's as far as they can go. That's okay. Just go there and come back down. Go here and come back down. Throughout the day, throughout the weeks, it's going to get better and better with your treatment and also with their mobilization. So something to keep in mind. I don't do a lot of upper trapezius and scalene stretches. I think the scalenes are a little difficult to treat. Obviously, there's 3 of them, and they're in different planes. So we're going to show the middle scalene here, which is very similar, of course, to the trapezius stretch, doing a contract, relax stretch. As you can imagine, if you did a little bit of ipsilateral rotation, you get the anterior scalenes, a little bit of contralateral rotation, you're going to get the posterior scalene. But she's doing a contract, relax stretch where she's pushing her head into her hand, hold for 7 seconds, and then go a little bit further. And as you can do this further and further, you can increase the stretch of those muscles and hopefully take a little bit of compression where we see a lot of our scalene type TOSs between the anterior middle scalenes present. I think this is one of the better exercises. In fact, this exercise has just been updated in ChiroUp to have a little bit of a caveat there, and it's in the actual protocol. So I think that the corner pec stretch, let's move that up a little bit, there we go, is you've seen this before. The cool caveat is that one of the things you can do with the corner pec stretch to actually open up and stretch that neurovascular bundle a little bit more is when she has her hands there, you can actually posterior tilt your scapula. So teaching them how to posterior tilt your scapula, kind of like the scapular repositioning test that we learned about in the scapular dyskinesis protocol, helps open up that space. And what she can do is she can put her elbow on the wall and then drop down a little bit. And that will help. And I'll show that at the very end. In fact, after this lecture right here, I'll show you a little demo on how to prescribe that report and then also with that exercise in there. So these are the stretches that I would do, the exercise that I would do for a patient with thoracic outlet syndrome. But don't forget about what the person's already doing to themselves. These people didn't wake up with TOS. Their lifestyle, the things that they do, the postural stresses, their workstation have all turned against that person to create this syndrome. you really need to avoid excess compression here. So things like a backpack, like you're seeing here, briefcases, laptop bags are just getting heavier and heavier, even with bra straps. In fact, my partner had a patient. She was a young female. I believe she was 15 to 16, and had a really tight sports bra. And the style of the sports bra cut her across this area, and she started to develop signs and symptoms. She had seen multiple providers, and eventually was deemed it was a sports bra. She went to a different style of sports bra and no longer had symptoms. They think that it could possibly be up here, but more than likely it was cutting her across here a little bit too tight. So something else to think about. Look at all things involved with the signs and the symptoms. I had a very similar case present where a guy came in. He had numbness and tingling across the back part of his hand. I looked at his imaging. He had a lot of degeneration in his neck. He had a positive radial tunnels nerve tension test. And I did everything that I knew to help with that. I looked at the radial tunnel syndrome. We looked at nerve flossing exercise. We looked at cervical traction. He had epidurals. He went through the gamut of things going on. It wasn't until he came back from a cruise that we came up with the solution. And what I noticed is that when he came back from the cruise, his wife had tripped and fell on the cruise, and he came in with her. And so he's sitting there with his wife, Sally, and I'm working her up. And I said, Bob, what's going on with your hand? I haven't seen it in a couple months. I know you were still having your symptoms. And he said, you'll never believe this, but once we got back from the cruise, it went away. And he had it for maybe 2 or 3 months before that, and it was a constant numbness and tingling. And I looked at his wrist, and he had a tan line for a watch. And I said, Bob, I didn't know you had a watch. And he said, I take it off every time I come in so you can work on my arm. And I said, well, where's your watch? And he said, I left it on the cruise. Well, he had one of those old watches that were metal and had a band in it that kept it, tight to his wrist. He wore it every single day. I never noticed it because he never had it on. He had it on every day on the cruise. That's where he got the suntan. But then he lost his watch before coming back. 2 weeks later, his numbness and tingling was going away because he wasn't constantly compressing that area. So, but by no means was I the one that broke the case. It just was one of those things that life happens, and now we have a better idea of what causes symptoms. But without taking away that watch, his symptoms would have never gone away. Very similar in a TOS type situation, a rotator cuff syndrome, someone sleeping on their shoulder, a TOS situation, constantly having tight bags, having that tight bra. Those are the kind of things that can add up to cause symptoms that, if unresolved, can cause future problems. And it really takes us digging into someone's life to really understand all the necessary components of that person's life and all the factors that have led up to this diagnosis. Because there's no treatment that's going to fix his tight watch being on his wrist. There's no treatment that's going to fix a too tight of a sports bra compressing the thoracic outlet. So those are all things that definitely think about in your evaluation. When it comes to surgical treatment, it's controversial. And the reason I say that is because sometimes it could possibly be caused by a cervical rib, but not all people with cervical ribs have TOS. So when it comes to neurogenic things, we really try to go through conservative management first. When you have neurological weakness, that has been there for a long time. Surgery is going to be on the table just a little bit, faster. However, if someone has vascular issues, people who have vascular, and definitely arterial, that if they have arterial issues, there was a past paper that if they just had that first rib resection, the people with vascular issues, 93 to 96% of them were fully resolved. Is it because of cervical rib? Possibly. Is it because of the rest, the decreasing activity after the surgery? Possibly. But you're removing some of the compression from that space-occupying lesion. So never be afraid to at least get a surgical opinion. And if we have atrophy, if we have weakness, if we have blood flow issues, I'm going to jump into that arena just a tad faster than a normal neurogenic type case. So just in conclusion, what we want to talk about with TOS is looking at their signs and symptoms, looking at their postures, their hobbies, their habits to see if this fits into the TOS type diagnosis. Numbness and tingling in the fourth finger is the most common symptom, which is 90% of people with TOS have those symptoms. If they have weakness, coldness, fatigability in the arm, they're not getting blood into the arm, very serious, drive to the emergency room. If they have a red, hot, swollen arm, then they're not getting blood back out of the arm. Still very serious. That's a 5%er. That's a venous type TOS. Have your staff drive them to the hospital. If it's neurogenic, that's us. Once we hit a weakness, we usually atrophy in the flexor muscles, a little more serious, nerve conduction velocity, EMG, doing some advanced studies might be a good option with ultrasound or MRI, depending on the availability of those types of advanced tests in your area. If it's not, we just have pain, numbness, tingling, paresthesia, the most common type, the 95%, that falls within us. Look at the neck like we always do, and then go out and see if there's any kind of peripheral problems at the scalenes, at the costoclavicular space, at the pectoral space. Treat it appropriately with the stretches and the exercise that we put out here, and don't forget your neurodynamic test. Have a patient do this, put their finger and their thumb together and try to look through the opposite side. If you're seeing tension with the ulnar nerve, there's possibility of, we'll call them spot welds. Doing your nerve flossing exercise will help with those peripheral symptoms. I hope this helps. What I'd like to do now is to show you exactly how to create a report for these types of patients so they can get all their exercises, get their information, and understand TOS a little bit better. And we can hopefully do that in a time-efficient manner that you can do what you do, and you can use this kind of patient education and exercise to help you get